kick off. So with no further ado, Dr. Assem Malhotra.
Thank you, Nathan, and I'm going to stand when I speak. I just prefer to stand. I think it'll be you'll get my message more effectively if I'm standing up. But I'm really honoured to be here. Thank you for inviting me to speak today. Really to spread a message of something I believe is very important that affects every one of us. If not us individually, it affects our relatives, our friends, our families. And I'm particularly honoured to have some really great people joining me today who are going to speak as well. So I'll start on my left-hand side. I've got Sarah Macklin, who is an eminent nutritionist from Britain, described by Marie Claire as the Jamie Oliver of the modelling world, and she'll be speaking to you a little bit later on. On the right of Nathan is Professor Hanno Pell from University of Leiden, who's a diabetologist and probably one of the most published and eminent respected diabetologists in I would say in the world. And on his right is somebody who's become a very good friend of mine in the last few years, Sir Richard Thompson, who was a personal physician to the Queen of England for 21 years and the past president of the Royal College of Physicians. So I'm really pleased that they are here today to really support what I believe will be ultimately a very positive message at the end of this whole session of what we can actually do to really improve people's health and revolutionise healthcare. So I'm going to start with a quote from the late, great Stephen Hawking. And I often tell my patients, for me and this whole journey that I've been on, it's been about the people that inspire me more than anybody else are my own patients. And I'm always learning from them. And I think the day we stop learning as doctors is the day we stop actually becoming proper doctors. So I think that we need to approach a lot of this, there's a lot of evolving science, but we need to constantly have an open mind. So as a doctor, I wish to practice evidence-based medicine. And this slide shows you what the real components, the most important components of evidence-based medicine are. And that is using our individual clinical expertise, as you can see, the best available clinical evidence. So last but not least, what's most important is patient preferences and values. And it's something I think we don't actually do enough of, and we are neglecting to a huge amount. And through this talk, hopefully that will make a lot more sense to you. And for the very purpose, ultimately, to improve patients' outcomes, to improve their health. So the man who's considered the father of the evidence-based medicine movement, Professor David Sackett, said, half of what you learn in medical school will be shown to be either dead wrong or out of date within 5 years of your graduation. The trouble is nobody can tell you which half. The most important thing to learn is how to learn on your own. And sadly, I've been a qualified doctor now for almost 17 years. I have slowly and reluctantly come to the conclusion that as it stands now, honest doctors can no longer practice honest medicine. We have a complete healthcare system failure and an epidemic of misinformed doctors and misinformed and harmed patients based upon a number of factors. So these include biased funding of research, so that's research that's funded because it's likely to be profitable, not beneficial for patients, biased reporting in medical journals, biased patient pamphlets, biased reporting in the media, commercial conflicts of interest, and last but not least, medical curricula that fail to teach doctors how to comprehend and communicate health statistics. So let me give you a few examples. So financial conflicts of interest and a culture to do more can often lead to a lot of unnecessary tests and investigations and put that ahead of what's most important to patients. For a minority, greed smothers the conscience. So one US cardiologist was jailed for ordering $19 million worth of unnecessary investigations and procedures. In the United States, they have a fee-for-service model, which incentivizes people to do more, give more treatments and do more investigations because they're paid for it. In the UK, we have something called payment by results, but in reality, although it's not to the same degree as the United States, effectively that's the same sort of thing that's going on. So let me just give you one example here. So I trained as an interventional cardiologist, so essentially having done cardiology, I subspecialized where I was doing, in layman's terms, keyhole heart surgery on patients. And I've done thousands of angiograms, where you diagnose people with coronary artery disease from this in procedure. But also we do something called stents. Now, many of you may know of stents. Essentially, it's a procedure where we unblock people's arteries by passing a tube into the arteries and inflating a balloon and deploying a small metal scaffold. But the reality is that although it's life-saving for people having a heart attack, and I'll tell you exactly how life-saving that is later, for people who are not having a heart attack, people who have stable heart disease, it does not prevent heart attacks or prolong life. And we have very good extensive evidence for many, many years that it doesn't do that. But it's estimated in America almost half of all the procedures for stents on many, many patients, costing millions and millions of dollars, actually is carried out, is of questionable value, despite this body of evidence. But most importantly, 88% of patients undergoing the procedure thought they were having the procedure for the very purpose which it doesn't benefit them. And when anonymously asked, 43% of cardiologists said they would still go ahead and do the procedure, even if they felt it would not benefit the patient. Now, this is not a procedure that doesn't come with harms. So at the end of mid-2013, and then following on several months later, I wrote 2 consecutive editorials by coincidence. The first one was in the BMJ, called Too Much Angioplasty, and the second one was in JAMA Internal Medicine. And the first article I wrote was actually pegged on the fact that I was emphasizing this level of misinformation actually no one is immune to. In fact, it probably, in this case, went all the way up to the former president of the United States, George Bush. So it was widely reported in America that George Bush received a stent for heart disease. However, apparently he had been cycling 100 miles a week before. There was no report that he'd had a heart attack. And as far as we know, he just went for a routine check under his cardiologist and ended up with a heart stent. And my guess is this, that ex-President Bush probably wasn't told it wasn't going to prevent him having a heart attack or prolong his life. So I basically wrote an editorial saying that actually we need to be more explicit with patients and emphasize the importance of lifestyle changes and medications that can help prevent heart attacks. But certainly this procedure, there isn't fully informed consent, because the actual procedure itself does carry a risk, a 1% risk of having a heart attack, stroke or death. And in my career, I've seen patients that unfortunately have suffered a complication that couldn't be predicted, where they've either had a stroke on the table or they've died. And I thought to myself, wow, this patient's symptoms weren't that severe, yet if they'd probably been left alone and hadn't had the procedure, they would still be alive today. Or they may have changed the decision-making process about, if they were informed about the actual true benefits of the procedure, they may have changed their mind and not had it done and still be alive. So, I emphasize that we should actually make this mandatory in the consent form to protect patients from these unnecessary harms. And the second editorial on JAMA Internal Medicine was really re-emphasizing that. It was press released and picked up by BBC News. And interestingly, the chairman of the Academy of Medical Royal Colleges, the body in the UK that represents almost every doctor, agreed with me, said this was a legitimate concern in the press release. The British Cardiovascular Intervention Society, interestingly, run by cardiologists who do heart stents, their response was they didn't think that changing the consent form was actually the best way to manage this problem, which I thought was very interesting. But clearly there is a bias there. What I didn't predict is several months later, JAMA Internal Medicine then published a paper where they actually gave this scenario to patients, see whether it would change the decision-making process. And it actually did significantly. When patients were told there wasn't a benefit from stenting for stable disease in preventing a heart attack, stroke or death, they changed their decision-making process, reducing the amount of people having a stent by about 25%. And it was estimated if this conversation was to go on, just a very simple, transparent conversation across the United States with cardiologists and their patients, then reducing the amount of unnecessary treatments would potentially save US healthcare $864 million a year, just from one conversation about one particular procedure. Okay, so misunderstanding of health statistics is also a major risk factor for misinformation. So many doctors, surprisingly, don't understand health statistics and therefore cannot evaluate evidence for and against a treatment. So in one study several years ago of 150 gynecologists, a third did not actually understand the meaning of a 25% risk reduction from mammography screening, so screening for breast cancer. Most of that third believed that if all women were screened, 250 out of 1,000 less would die of breast cancer. But actually, when you look at the data, you'd have to screen 2,000 women to prevent one death from detecting and saving them from breast cancer. So 1 out of 2,000 is actually the actual figure. And a smaller study that was carried out a few years later, despite this awareness, although many of the doctors asked knew about the benefit not being that great, none of them were aware of the harm. So for every one lady that was saved from breast cancer from screening, 10 were harmed by receiving an unnecessary treatment or an operation. So let me just give you a very basic, simple, mathematical education on statistics here. And it's not rocket science, and I think this is a crucial part. So there are many ways of actually presenting a benefit. A relative risk or absolute risk, also known as the numbers needed to treat NNT. So if you communicate relative risks, as opposed to NNT or absolute risk, it can actually lead lay people to, and doctors also, to overestimate the benefits of a treatment. So let me give you an example. For people with type 2 diabetes, the published medical literature, tells us that if you take atorvastatin, a cholesterol-lowering drug, 10 milligrams every day for 4 years, there's a 48% relative risk reduction in having a stroke. That sounds quite impressive. You're 48% less likely to have a stroke if you take 10 milligrams of atorvastatin every day for 4 years. But what does that actually mean when you look at the data? Well, it means you reduce the risk of having a stroke from having no treatment, no statin, from 28 in 1,000 to 15 in 1,000, which means there's an absolute risk reduction of 1.3%. So what does that mean for the individual in real terms? The actual way to say to that patient is if you take atorvastatin 10 milligrams every day for 4 years, there's a 1 in 77 chance that the drug will prevent you having a stroke. Very different to 48% relative risk reduction. Most people do not benefit. The benefits are small, but you may decide that that benefit is good for you, or you may decide it's not. It's very different. Now, mismatched framing in medical journals that we rely on to give us information about benefits and harms of medications has made the situation worse. So, if treatment A reduces the risk of developing a disease from 10 to 7 in 1,000, but increases the risk of the harms from 7 to 10 in 1,000, the journal article will present the benefits as a 30% relative risk benefit or reduction, but the harms as 0.3% when they're exactly the same thing. How common is this? Well, one analysis looking at articles, a third of articles, in fact, published in the BMJ, JAMA, and the Lancet between 2004 and 2006 use mismatched framing when presenting information on the benefits of a drug and the harms. It's extraordinary. This is not science. This is marketing. And this asymmetric presentation of, obviously, benefits and harms was going to lead to overtreatment. It's going to exaggerate the benefits of a medication and reduce the risks, or the perceived risks. And by the way, this is all still best case scenario. I'm going to go further deeper into this as well shortly. So don't just take my word for it. The man considered probably the world-leading researcher in health literacy in Berlin, Gerd Gigerenzer, he said in a World Health Organization bulletin in 2009, it is an ethical imperative that every doctor and patient understand the difference between absolute and relative risks to protect patients against unnecessary anxiety and manipulation. In other words, and this is what I believe to be true, unless you have this conversation with a patient, unless your doctor tells you the absolute benefit of a drug you're going to take, then it's not being ethical. I think this is unethical practice. That's essentially what Gerd Gigerenzer is saying. But we are unwittingly practicing unethical medicine. Most doctors want to do the right thing, but they're misinformed. Let me give you a case study. People like case studies. They're interesting stories that kind of tell you a lot of different interesting things about what we're speaking about today. So I saw a patient, 48-year-old man, had type 2 diabetes. He'd been seen in outpatient several months after having a heart attack. He'd received a stent. He'd survived, and he was put on a cocktail of medications. And he comes back to see me in clinic, and he's reporting very disabling chest pain. Now, as a cardiologist, if you've had a patient who's had a heart attack and had a stent, and there's often sometimes some other underlying disease there, you worry either has a stent blocked off as a new disease, but the history, most importantly, didn't suggest anything serious. But just to be on the safe side, we decided to book him for a repeat angiogram to look at his arteries and check things are okay. He was clearly not having a heart attack, but there may have been a new blockage that was causing him problems. So we booked him for an angiogram. I did the angiogram. I looked at his arteries. Everything was fine. It was very reassuring. And I said to him at the end of the procedure, listen, everything's okay, there's nothing wrong with the heart, this could be coming from your stomach. Because he said, well, doc, that's great, but why have I still got this pain? What am I going to do? I said, this could be coming from your stomach. Sometimes chest pain can be coming from the acid reflux. So we put him on some medications and said, go back to your GP or general practitioner, and we'll follow you up and see how you get on. So he was reassured, put on this proton pump inhibitor drug. He comes back 6 weeks later, arranged to see him, and he said, listen, this pain is still there, it's getting worse. I've also got these other things I didn't mention before. I've also got these muscle aches and I'm feeling fatigued. He was with his wife, who was also very worried because he's now depressed, and she says he's been depressed now for months because of these pains, disabling pains that he's got. I spoke to one of my colleagues and he said, oh, look at his medications, maybe it's something in the medications. Maybe it's a statin. I thought, well, that's interesting. Statin causing these side effects? Okay. So I said to him, listen, we're going to stop your statin for a couple of weeks, go back to your GP and see what happens. Now, what's happened in the meantime is GP has already referred him to a gastroenterologist. So he's now about to go and get because the drug that he took for his so-called chest pain that was thought to be maybe coming from the stomach wasn't helping him. So he's now about to go and have an endoscopy. So an invasive investigation where he's going to have a telescope camera passed into his stomach to look for an ulcer. So this is being organised. I can't see him just because obviously, the way things work, it's a non-urgent case. So, I arranged to see him a few months later, but he turns up uninvited. A week later, he turns up to the clinic, knowing that I'm in clinic, and he knocks on the door and he comes in. And he says, thank you, doctor. After months of misery, I've stopped his statin. My pain has disappeared, but now I'm worried. My GP has said you must never stop your statin or you will die. Okay, now, I want to ask the audience here, does anyone have any idea roughly what his risk of death is? So he's taken a statin, he's had a heart attack, there's evidence-based that statins are beneficial in people with heart disease. But what do you think his risk of death is from stopping a statin for 2 weeks? There may have been causing side effects, he's had a heart attack. Any guess here, in terms of percentage figures here? What do you think? 1 in 100, 1 in 50, 1 in 10? Any guesses from the audience? Anyone that hasn't heard me say this before?
Go ahead.
0.
Okay, 0. Well, maybe you know something I don't. Probably very close to 0. Probably worst case scenario, based upon the published evidence, 1 in 10,000. So this chap's risk of death for stopping a statin for 2 weeks is 1 in 10,000. Yet the GP has said, you must never stop your statin or you could die. Okay, so clearly there's an issue there. Now, in the end of 2013, there was a controversy that started because there was calls that were coming from various quarters of academia suggesting we should expand the use of statin drugs to more people taking it, essentially healthy people, which in effect would reduce the threshold for prescription of statins based upon people's risk factors and ultimately lead to suggesting every person, every adult over the age of 50 should take a statin drug. So John Abramson from Harvard and colleagues did an analysis of data that was already published, by the way, most of it all industry sponsored, to actually see whether there was any benefit in terms of reducing death rates in people at low risk of heart disease. And in the editorial, they said that there was no mortality benefit. In other words, you will not live 1 day longer from taking a statin. But also, he suggested actually we should be concentrating more on lifestyle changes. 80% of heart disease is related to lifestyle, diet, exercise, that kind of thing, smoking reduction. And by coincidence, in the same paper, in the same journal of the BMJ, I also wrote an editorial which was called "Saturated Fat is Not the Major Issue," and that editorial was press released by the BMJ and became a big news story. It was front page of 3 newspapers. It went all around the world, essentially because a cardiologist is coming out and saying, God forbid, saturated fat that we think clogs the arteries actually doesn't clog the arteries at all. The data doesn't support that, and if we should be turning our attention to sugar. But in the same editorial, I also mentioned the fact that we've overprescribed statins to millions of people because there was no benefit for low risk, and the side effects, based upon some observational studies and my own experience, is probably affecting 1 in 5 people. Now, the side effects are unacceptable, essentially, to patients. But there was a backlash a few months later. So this got a lot of attention. The saturated fat was the main story, but a few months later, Professor Sir Rory Collins of Oxford University, considered probably the leading statin researcher in the world, who's done lots of drug trials on statins, he came out and in the front page of the Guardian newspaper in March 2014, several months after the papers were published, he basically called for retraction of both John Abramson's paper. John Abramson said the same thing about side effects that I did. and said that this could cause, unnecessary deaths of people stopping their statins from fear-mongering. It's interesting, he said that, the serious side effects were very rare, and essentially that, these symptoms are very, very rare. From our data, we don't have any evidence of any significant side effects. So ultimately what ended up happening was this then it went for a review. There was a lot of pressure on the editor of the BMJ, Fiona Godley, and I think rightly so, that she decided to send both articles for review to see whether they should be retracted by an independent panel. While this was going on, in the interim, NICE, National Institute of Clinical Excellence, our health watchdog, interestingly, came out and decided that we should be giving statins to more people and we should prescribe them to low risk, which will ultimately result in GPs being financially incentivized to prescribe statins to people at low risk of heart disease, despite the fact there was no mortality benefit. The non-mortality benefits at best were about 1 in 140 of preventing a non-fatal heart attack or stroke. So they came out, but there was a response. Actually, a number of doctors, eminent doctors, including Sir Richard, who is here, Richard Thompson here today, the former chair of the Royal College of General Practitioners, a number of other doctors wrote a letter to the Secretary of State for Health and the chair of NICE to say, actually, we think this is not a very good idea. We think it will ultimately cause more harm than good. And we gave a number of reasons in a very extensive document. I was also a co-signatory, saying that basically all of the guidance on statins was based upon industry-sponsored studies, which is a crucial element of all of this. The side effects weren't taken into account, including type 2 diabetes. We know statins do cause type 2 diabetes in probably about 1% of people. And most importantly, there's a mortality benefit. These patients are not going to live one day longer. So mass prescription of statins ultimately we thought would actually put more pressure on the system and wasn't a good idea. So this actually got a lot of attention. It became a big news story. And this was while this whole review panel thing was going on. And the review panel came back 6-0 in our favour, saying there was no reason for retraction. There maybe was a minor correction that needs to be made about the quality of study that was used to make this claim about 20% side effects. And that should have been the end of it. Also, the General Practitioners Committee backed us as well, because they said that because we don't have access to all the raw data on statins, and also based upon the fact that the UK stockpiled Tamiflu, which we spent £500 million on a drug that ultimately, when independent researchers were able to access the data, revealed was no better than paracetamol for helping people for influenza, until we get access to the raw data, we actually, as general practitioners, the ultimate committee that would help decide, make these recommendations, they revolted. This was unprecedented against the health watchdog. The other issue as well that I didn't mention is that NICE, the panel who were involved in making the decision on recommendations, several members of the panel had direct financial ties to the drug companies manufacturing statins. So again, we felt this was a bias. Now, the saga continued. It didn't stop there. And I'm going to jump forward because I know we don't have a lot of time, but essentially what ended up happening then is Professor Collins then referred, he was not happy, there was no retraction. Professor Collins, who felt very strongly that there was a over-exaggeration of the benefits, of the harms of statins from side effects, he referred the editor of the BMJ to the Committee of Publication Ethics for editorial misconduct, which some people felt, if she was found guilty, would have resulted in her sacking. And it may well have done. Luckily, that didn't happen. But after this, The Lancet then published a paper basically suggesting that we've now done a reanalysis with the same researchers who suggested statins are great, including Professor Sir Rory Collins, who's one of the lead authors, to say that actually, no, statins are great, there's no issue of side effects really, it's very little, and overall the benefits outweigh the harms even in low risk. The Sunday Times does an investigation about a month after that was published in The Lancet, so John and God Thomas. And what he found was really interesting, and I think, is certainly puzzling to me. So he mentions Professor Collins' work where they'd then come to the conclusion maybe 1 in 50, 1 in 100 people may suffer muscle symptoms from statins, although it's reversible, and that's true. Professor Collins, who also believes more people should be taking statins, is a co-inventor of a test that identifies susceptibility to muscle pain from statins. That's interesting. The test, which was branded as Statin Smart, was sold direct to the consumer for $99 on a website that claims 29% of statin users will suffer muscle pain, weakness or cramps. And the marketing material also claims that 58% of patients on statins stop taking them within a year, mostly because of muscle pain. And that's true. When you ask patients why they stop their statins, most of them stop them within a year. They say because they get muscle pain and symptoms. Royalties from licensing of the patent can be used to fund university research, but Professor Collins waived his personal fees. And Boston Heart Diagnostics, interestingly, that they stood by their claim. They had the license on the actual test. And they said that randomized controlled trials, such as those used in the Lancet study authored by Collins, had major limitations because patients with statin intolerance were often excluded. So that's part of the problem, is the actual trials don't reflect a lot of patients who must suffer muscle symptoms, partly because in run-in periods, before the trial starts, people who are non-adherent to statins are taken out, probably because of side effects in my view, and also the people in the drug trials themselves often don't represent the people we see in the real world who are on statins, who have lots of different illnesses and maybe older, for example. John Unger Thomas then did a Freedom of Information request to find out whether Oxford University and Professor Rory Collins' department had received any money from the sale of this test that tells you whether you're likely to get muscle symptoms from statins by testing for a gene. And what he found was, yes, they had received, University of Oxford had received over £300,000 for the sale of this, and Professor Collins' department had received over £150,000. And this thing that he invented, he was a co-inventor on, actually came to fruition in 2009. 2009. So I'm puzzled by this. If the side effects are so rare, my question is, why would you invent something to test for side effects and make money out of it, or your department make money out of it? I'll let you draw your own conclusions. So let's just take a step back for a second. You know, there is a system failure. There's a bigger picture, and I think we need to acknowledge something else. Peter Wilmshurst, who's a cardiologist, a very respected cardiologist in the UK, in the Centre of Evidence-Based Medicine in 2014, giving a talk, he points out a few, I think, really important points. First of all, pharmaceutical companies and medical device companies have a legal obligation to make profit and declare a shareholder dividend by selling their product. They are not required, although we would believe it to be the case or hope it to be the case, they are not required to sell consumers, patients and doctors the best treatment. But what he says is the real scandals are this: regulators fail to prevent misconduct by industry, and doctors, institutions and journals that have responsibilities to patients and scientific integrity collude with industry for financial gain. Peter Wilmshurst has just submitted evidence I'm going to talk about briefly now to the Science and Technology Committee in the UK, who are investigating research misconduct and scientific integrity. And here are a few key points that gives you a bigger picture issue of why this is a system failure. First of all, academic institutions bear responsibility to publish. So there's pressure to publish for career advancement, and that can result in research misconduct. A record of prominent publication can actually attract future funding, often from drug companies, and good publicity, which institutions obviously like. Other pressures for misconduct come from association with industry. He says some publications are simply organized criminal activities, which may be at the behest of the sponsors, when prominent academics are paid large sums of money to publish false data by industry, or a sponsor may be one of the victims when payments for conducting research are made to the investigators who simply fabricate data. Medical journals have a financial pressure to publish positive findings of research on drugs and medical devices because their manufacturers buy reprints for the papers of distribution of doctors that then pay for advertisements as well, linked to articles that are favourable to their product. So to protect their reputations, academic institutions conceal research misconduct, destroy evidence, and silence whistleblowers. By the way, if you look at the document which is available online, you can find examples of all of this. I'm not going to go through it because I think that would be unfair, but you can find this. Journals are reluctant to admit that they have published flawed research, so they commonly refuse to publish failures to replicate. Fear of libel action contributes to the failure to expose research misconduct. Because lenient sanctions are imposed, institutions believe that the misconduct is not very serious and therefore fraudsters are not deterred. And he says the best way forward really is for criminal action for certain forms of research misconduct, and I agree with him. Now, one example here, one Dutch researcher in 2011 was found guilty for publishing fictitious data on the use of beta blocker drugs for non-cardiac surgery. And he was expelled from his institution. But what was very extraordinary is that his research, many papers were published in very high-impact journals. He influenced European Society of Cardiology guidelines. And this research, it's estimated that it resulted, the use of beta blockers where it wasn't indicated ultimately, when it was found that this data was dodgy. It's estimated that over Europe, over 8 years, across Europe, this was responsible for 800,000 excess deaths. 800,000 excess deaths. Peter Gosha, co-founder of the Cochrane Collaboration, who's done a lot of work in this area around research misconduct, scientific integrity. He wrote a piece in the BMJ not so long ago. He's written a book about this. Is actually one of the other issues is the fact that there is a lot of problems of major pharmaceutical companies being found guilty for fraud, essentially. In the United States in particular, between 2009 and 2014, there was a total of around $14 billion worth of fines paid for illegal marketing of drugs, hiding data on harms, which involved the majority of the top 10 pharmaceutical companies. But the problem is that there is no incentive for them to stop doing this. There doesn't seem to be anything changing the system. And what he says is that if you commit crime and crime pays, you commit more crime. And that's what they are doing. Let's talk about the innovation crisis. We keep hearing about, we need more innovation, more innovation. Well, what innovation have we had in the last couple of decades? Between 2000 and 2008, of the 667 new drugs approved by the FDA, only 11% of them were found to be truly innovative. Most of the other drugs that have been produced have essentially been copies of old ones at great cost and no extra benefit. And perhaps not surprising when drug companies spend at least twice as much on marketing than they do in research and development. So we're not investing enough in research, we're not going to get new blockbusters, are we? The former editor of the New England Journal of Medicine says it's no longer possible to trust, this is the highest impact medical journal in the world, by the way, says it is no longer possible to trust much of the clinical research that is published or rely on the judgment of trusted physicians or authorities of medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. That's quite extraordinary. Is she alone as a journal editor? No, she's not. Richard Horton wrote an editorial in 2016, and he said possibly half, according to people that he'd met, senior academics who he said will remain anonymous, possibly half of the published literature may simply be untrue. Because of several recent scandals in British universities, Richard Smith, former editor of the BMJ, also wrote, "Something is rotten in the state of British medicine and has been for a long time." And he refers to speaking at an event with lots of academics where he asked the audience, how many of you are aware of research misconduct taking place in your career in your institution? And he said about a third to a half put their hand up. A third to a half. He said, how many of you reported it? They all put their hand down. Okay, so has overemphasis on drugs. And by the way, just to add another really relevant, important piece of information, Professor John Winidis from Stanford University, a very eminent professor of medicine and statistics, he published a paper recently where he looked at the quality of research that's published in many clinical interventions, published in big medical journals, and of the 60,000 interventions, clinical studies that were published, he said only 7% of them fulfill criteria of actually being high quality and relevant to patients. 7%. So, has overemphasis on medicine detracted from lifestyle? Absolutely. We have a major public health crisis, as many of you know. We hear stories about this constantly now, the obesity epidemic in the UK that's now considered the fat man of Europe. More than 60% of the adult population are overweight or obese. More disturbingly, almost a third of children are in the same category by the time they leave primary school, and the trends are getting worse. Obesity itself costs the NHS, National Health Service, about £5 billion per year. That's expected to increase. But actually, the bigger issue is type 2 diabetes. So the direct and indirect cost of type 2 diabetes in the UK now is about £20 billion per year, both for treatment of diabetes, NHS costs, and also lost productivity, indirect costs due to lost productivity, so to the economy. And that's predicted to hit 40 billion by 2035 if we do nothing. I think the most important thing, I mean, we'll talk about some of the dietary controversies shortly, but really the processed food environment is at the heart, the obesogenic environment is at the heart of this problem. It's become almost unavoidable to avoid sugary processed food wherever you go, whether you go to the petrol station, whether it's on the high street, whether it's in gyms and health clubs. For me, and where my journey started, and what I find the biggest scandal, is that we've even allowed our hospitals to become a branding opportunity for the junk food industry. Several years ago, when I started on this campaign, I remember operating on a man in the middle of the night who'd come in with a heart attack. We'd done emergency keyhole heart surgery on him. He did very well, in his 50s, a little bit overweight, smoker. The next morning on my ward round, I'm actually telling him, you know, you need to take these pills, including statins, religiously. I said, you need to stop smoking and you need to eat a healthy diet. And just as I'm telling him about following a healthy diet, he gets served a burger and fries by the hospital. And he looks at me and he says, "Doc, how do you expect me to change my lifestyle if you're serving me the same crap," pardon my language, "that brought me in here in the first place?" And I looked around me, and I've been a very, I would call myself a foodie, if you pardon the term, most of my life. I like eating good food, I love cooking. And I couldn't find any decent food in the hospital I was working at, and in most hospitals. But I also looked around at my colleagues. 50% of 1.4 NHS employees are also overweight or obese. That includes doctors and nurses and non-clinical staff, all to the same levels. And really that proves that education is ineffective when the food environment is working against you. But of course, there's the illusion of protection. And actually a study showed in JAMA Internal Medicine, where they looked at people at similar risk and followed them up over a number of years, people on statins ended up heavier than people that didn't take statins. And we see that with our patients. But it's not just patients. One professor of cardiology, I won't name, I spoke at a conference with him recently, and he's a very eminent, respected professor of cardiology, and he got up on stage and he said, and I thought this was quite funny, he says, if you come from a C. Malhotra school of preventative medicine, you can prevent heart disease by eating berries and dancing in the woods. It's quite funny, I thought. But then he said seriously, he said, but if you're like me, pointing to himself, and you can't be bothered doing any exercise, you can take a statin. So he believes that. I'm sure other people believe the same. But, get this. For low risk of people with heart disease, we're talking about the majority of people taking statins worldwide, by the way, and it's estimated that probably close to 100 million people taking statins. Most of those people are not high risk of heart disease. They're not going to live one day longer from taking a statin. There may be a small benefit in preventing a non-fatal event, but overall it's not going to add a single day to their lifespan. Yet most of them don't know this. So I did this is anecdotal of course, a Twitter survey, and I said, well, to people out there, would you take a statin knowing it's not going to add a day to your life? 92% of them said no, they wouldn't. Where does diet fit into all of this when you look at chronic disease? Well, actually now it's estimated, and this is not a perfect science by any means, but you know, this is pretty extraordinary stuff. Poor diet now contributes to more disease and death globally than physical inactivity, smoking and alcohol combined. So where should we focus on the diet? Well, before we talk about that, and Nathan mentioned this before, and it's really great to hear a politician, it's rare to hear a politician saying we need a top-down, this is not going to happen from even 1 million people who end up watching this, even if we were to sell 1 million books or 20 million books giving this evidence. Ultimately, the food environment's working against you. It's going to be very difficult to exercise healthy choices. So this is Tom Frieden's health impact pyramid, and it basically says that changing the context and making the healthy choice the default choice will have more impact than counselling or education. So it needs regulation, and there are lots of examples of this, not least tobacco. So when you look at cardiovascular disease deaths over the last 3 decades, they've dropped dramatically. The biggest impact, responsible for at least 50% of that decline, has come from smoking cessation. And that happened not from education. Education is important, I don't deny that. But it came from targeting what we call the 3 A's in public health: the availability, the affordability, and the acceptability. One amazing example of this is in 2002 in Helena, Montana, in the United States, when they brought in a public smoking ban. Within 6 months, there was an absolute reduction, not relative, absolute reduction, 40% reduction in hospital admissions for heart attacks. Within 6 months of a smoking ban. And when the tobacco lobby weighed in and the law was rescinded, the emissions went back to the same levels as before. How can you explain that? Very briefly, passive smoking basically increases platelet activity, makes your blood more clottable. So when you remove the passive smoke out of the environment, people are less likely to have what we call plaque rupture and clots in their arteries that result in heart attacks. And taxation on cigarettes actually was responsible for the biggest decline in smoking, more than anything else. So the effectiveness hierarchy means if you have policy-based interventions, it will be more effective because it will reach more parts of the population and is not dependent on sustained individual response. So sugar has got a lot of attention recently. I've been somebody that has, as part of a group of people, I've been campaigning on this issue for a long time. But why should we pick on sugar? Well, it was 1972 that British physician and nutritionist John Yudkin wrote a book called Pure, White and Deadly. And he said, in the 50s and 60s, he looked at data and did research, and he said sugar was a major issue and we should target sugar. The reason that this came about is because heart disease deaths were increasing from 1920, peaking in around 1960. And there was a concern about what was happening. Why was this, what was the cause of this increase? So John Yudkin said it was sugar, and sadly, he was hung out to dry because another researcher, Ansel Keys in America, felt that saturated fat was a major problem, and his message was taken, and the sugar industry basically did whatever they could to discredit John Yudkin, even using various methods he talks about to impede his work, interfered with his research and publication. Ansel Keys, it's reported, actually, essentially called out Yudkin's work as being fraudulent. I mean, it was really quite extraordinary what happened to Yudkin. He was on his own, he was hung out to dry, and he died in 1995, and his warnings were no longer taken seriously until this man comes along, Professor Robert Lustig, Professor of Pediatric Endocrinology in the University of California, San Francisco, and he publishes an editorial in Nature basically saying that sugar is the problem, sugar is toxic, sugar has become unavoidable. From his data, it's responsible for metabolic disease. Type 2 diabetes is clearly linked to obesity. And he did a YouTube lecture as well, which has now got 6 million views, which is quite extraordinary. So I remember reading this myself. How did I get involved with all of this? I read a news story on the BBC website about Robert Lustig, and I thought, it's interesting. I'd already started my kind of obesity campaign. When I'd done this, looked at this, when this patient came in, and we talked about junk food in hospitals earlier, I wrote a letter, actually, an email, by chance, just to Jamie Oliver. I got his PA's email address from a journalist friend of mine, and to my pleasant surprise, about 6 weeks later, Jamie emailed me back. I thought what he'd done about highlighting the importance of how bad school food was, I thought he could do something about hospitals as well. And to my pleasant surprise, he replied back and said, Jamie would be thrilled to meet you. And I met Jamie several months later and discussed all of the issues with several eminent doctors about what we needed to tackle obesity. But in all of that, while that was going on, and obviously we knew that we needed to have public health campaign to target marketing of junk food, etc., I started looking and researching sugar after seeing Lustig's work. And essentially, I learned a few things myself. As a doctor, as a cardiologist, it may surprise you, but in medicine, we don't get taught anything. I don't remember very little about nutrition in medical school, hardly anything. So first of all, I found out, well, actually, added sugar, you don't require any carbohydrate for energy from sugar at all. It's not required. And studies had started to show that sugary drinks were linked to weight gain and obesity. And the other thing that had been sort of neglected and hadn't got enough publicity was the fact that the most common cause of chronic pain and hospital admissions in young children in the UK is tooth decay. And the single biggest factor, maybe the only factor causing that, the only thing that you ingest that directly erodes teeth enamel is sugar. So, the common wisdom is that, had been that a calorie is a calorie and sugar is just empty calories. And, but what we know actually is that when you look at the data, excess consumption of sugar promotes something called insulin resistance, which is the number one risk factor for heart attack. And 66% of people admitted to hospital now fulfill criteria of something called metabolic syndrome, which is essentially insulin resistance, which is linked to sugar consumption and excess refined carbohydrates. And that basically is any three of the five there, of high blood pressure, high triglycerides in the blood, low HDL, which is good cholesterol, and increased waist circumference. And to put this in perspective, and this is a slightly crude slide, and this is why I also say there's no such thing as a healthy weight. Up to 40% of people with a normal body mass index will actually have metabolic abnormalities linked to metabolic syndrome. And so it's not about obesity. Obesity is actually, it's a major problem, but it's a marker of a much bigger problem. So we should be focusing on metabolic syndrome, which is where all the health issues and concerns and the costs come. And that includes pre-diabetes and type 2 diabetes also. So what does Coca-Cola say? Well, they say they want to get involved in helping us solve the obesity crisis. They say beating obesity will take action by all of us based upon one common sense fact: all calories count, no matter where they come from, including Coca-Cola and everything else with calories. That's the fiction. The science tells us that all calories are not the same. I don't think anybody here in their right mind would think that getting a calorie from foods fibrous versus protein versus fat versus fructose has the same metabolic effect on the body. Of course it doesn't. Different nutritional value, different metabolic effects on the body. And this is probably one of the most key studies that I've cited several times in stuff I've published. And basically, this was carried out by Stanford researchers looking at what in the food environment predicts type 2 diabetes in the population. And they looked at 175 countries worldwide, and what they found, for every excess 150 calories that was available for consumption that came from sugar versus fat or protein, there was an 11-fold increase in the prevalence of type 2 diabetes. But crucially, this was independent of body mass index and independent of physical activity. So in other words, a way to interpret that is, even if you're a normal body mass index and you exercise, but you consume too much sugar, you're increasing your risk of getting type 2 diabetes, which is pretty extraordinary. And later on, I wrote a piece called "You Can't Outrun a Bad Diet," which was also based upon this research here. So then I started looking at, I looked at the research on sugar, and I was doing an investigation, a bit of research myself for the BMJ. And all of these things were mentioned in that editorial. And one thing that really shocked me is that I looked at what the American Heart Association was saying, because there was no recommendation, how much sugar should we be consuming? The American Heart Association recommended in 2009 that the average adult male should consume no more than 9 teaspoons of sugar, female 6. US Department of Agriculture said for the average 4 to 8 year old child, no more than 3 teaspoons of added sugar per day. Now I've put this slide up because this is really, I still think, is extraordinary. So this is labeling across Europe, in the UK and across Europe, about how much sugar you should consume. It's a bit blurry, but essentially it says that, shows a typical can of Coca-Cola, which has, it has about about 9 teaspoons of sugar in it. And according to this labeling, it basically says this represents 39% of your guideline daily amount of sugar consumption. So in effect, it's saying, for a consumer that looks at the label, you should be consuming 22.5 teaspoons of sugar a day as part of your guideline daily amount. That's really extraordinary. So I thought, hold on, there's a bit of a disconnect here. The American Heart Association is saying 6 teaspoons or 9 for a male, and the labelling saying, and the limit they're saying this, the labelling's telling us to consume 22.5 teaspoons of sugar a day. Incidentally, we know that the average consumer across Europe is consuming close to that anyway, so they are following the advice on sugar, on added sugar. So this is what they said, the American Heart Association. Professor Lustig was also part of that document. So he's an independent scientist. He has no industry links whatsoever. I respect him for his scientific integrity, very much so. And this is what they said. So what does the food industry do? The other thing I looked into this, I found basically in my investigation that the food industry had influenced the guidelines on sugar. But what they've done for years is they've said that it's about personal responsibility. That's the cause of the unhealthy diet. We're actually irresponsible. The nation is getting fatter because we're all greedy sloths, essentially. They raise fears that any intervention, like taxation, for example, banning junk food advertising, usurps personal freedoms. But we have to remember the greatest public health successes that have happened, whether it's safe drinking water, seatbelts in cars, smoke-free buildings, have all happened because of regulation. And there's another myth out there. We have this aging population, yes. We've added about 30 years to our lifespan since 1900. 30 years. 25 of those years have not come because of personal responsibility. They've come because of regulation, because of these interventions here. Of course, medical treatments have had an impact as well, but that's mainly from antibiotics for infections and acute treatments as well. What else they do? Well, and many of my colleagues and friends have been victims of this, and it's still ongoing, is that anyone that really suggests there should be regulation gets attacked. So they call us leaders of the nanny state, food fascists. They say that what we talk about, the sugar being a problem, that we are peddling junk science. So this is a very common part of the corporate playbook. And Kelly Brownell, Professor of Public Policy in the United States, has written a very amazing, really an inspirational paper on this, which is called Big Tobacco Played Dirty and Millions Died, How Similar is Big Food? And just to put this in perspective, well, so the other thing as well to mention is that they emphasize physical activity over diet. Now, I'm very passionate about exercise, almost obsessively from a personal perspective. I've got a bias. You know, I have played a lot of sports. I've captained sports teams at school and university. I go for walks every day. I go to the gym every so often. So I'm very active because I enjoy it. I know it's good for my health. But one thing that's very clear when you look at the data, when it comes to obesity, there's almost no link whatsoever between exercise and weight gain. It's all diet. That doesn't mean you shouldn't exercise. You shouldn't be sedentary. Of course you shouldn't be sedentary. But actually that benefit is for everybody. It doesn't matter your age and size. But when it comes to the obesity epidemic specifically, all of it is diet, diet, diet. But this is what they do. For a long time, a lot of people believed it's because of lack of exercise. And let's learn from history. It took 50 years from the first links published in the British Medical Journal suggesting there was a link between smoking and lung cancer before we actually had any effective regulation, because the corporate playbook of big tobacco, they successfully adopted the strategy of planting doubt, denial, confusing the public, and even buying the loyalty of scientists. And the extent of that denialism, even as late on as 1994, the CEOs of every major tobacco firm went in front of US Congress and they swore under oath they did not believe nicotine was addictive or smoking caused lung cancer. That's the extent of that denialism. So I wrote this piece in the BMJ, 2013 May, to really try and raise awareness of sugar. It wasn't really getting any attention in the UK. I'd read Lustig's stuff. I wrote about this and saying the dietary advice needs to change. We are recommending too much sugar to people. There's a big problem of sugar consumption across the board. Most processed foods have added sugar. It got press released, and I ended up going on BBC Breakfast and spoke to Susanna Reid and Bill Turnbull, primetime slot. It got picked up in some newspapers, the LA Times as well. And I discussed this, and interestingly, Bill at the end of it turned to the camera and he said, we should emphasize that we did ask 10 different companies or organizations associated with carbonated beverages, supermarkets, sugar manufacturers, to discuss this with Dr. Malhotra. All of them were unavailable. I was very disappointed. Right, so moving on, lots of things happened. I got contacted by various scientists. I helped form an organization called Action on Sugar. We then decided there needed to be a real big public campaign, and doctors needed to get on board to say sugar was the major problem. And we launched a campaign at the beginning of 2014. I was a science director, one of the founding members of Action on Sugar, and it made headlines, pleasant surprise, the Daily Mail, who many people would consider a newspaper that is right of centre, saying sugar is a new tobacco and really supporting our calls for regulation, which was really quite extraordinary. It became a very big story. It became a world news story, in fact. And we made great progress initially for the first few days, yet then the empire struck back. So Andrew Lansley is the former Secretary of State for Health, and he got up in Parliament because we had some support, actually. We had political support. Keith Vaz, who's chair of the All-Party Diabetes Group, actually came out and made an early day motion calling on MPs to sign up to say, we support Dr. Malhotra and his colleagues in Action on Sugar, that there should be a campaign to reduce sugar consumption in the population. Mr. Lansley got up 2 days later in Parliament and he said this. He said, he dismissed this early day motion and he talked about the sugar new tobacco. He said, the analogy between sugar and tobacco is not appropriate. Sugar is essential to food. I thought this is interesting. So I saw this and then I wrote a piece in The Observer a few days later, which got a lot of attention. It was called, basically, this is an excerpt from this, sugar is public enemy number one in the Western diet. So I wrote about Mr. Lansley. He attempted to rubbish respected public health professor Simon Capewell's statement that sugar is a new tobacco. It was in the press release. Lansley then compounded his errors by ignorantly asserting in the House that sugar is essential to food. It is not. He would have been more accurate in saying sugar is essential to food industry profits and lining the pockets of its co-opted partners. Lansley was a paid director of marketing company Profero to the end of 2009. Profero's clients have included Pepsi, Mars, Pizza Hut and Diego's Guinness. We didn't hear from Mr. Lansley again. Then, again, to our surprise, Dispatches and the Sunday Times did an investigation. Maybe I shouldn't have been surprised. I didn't know about this. When I wrote the piece in the BMJ, I called on the Scientific Advisory Committee on Nutrition to change the guidance. And then an investigation by Dispatches found that several members of the actual committee that decide on dietary advice in the UK had direct financial ties to confectionery giants. Ultimately, what happened, which was a really great result, the World Health Organization very shortly later came out with revised guidance and said that the maximum consumption of sugar, ideally for the average adult, should be no more than 6 teaspoons a day, which is great. And we got a meeting with Jeremy Hunt, who asked for us for a child obesity plan. And really, we summarized a few things there. Essentially, what I've talked about before about curbing the availability of sugar. And we did say that we should have a sugary drinks tax as well. And we gave this plan to him. As you know, we recently, just last Friday, a tax on sugary drinks, a levy on sugary drinks was introduced in the UK, which I think is a tipping point, and really I think will be a historical moment. There's no room for complacency to reducing the obesity epidemic. But the other interesting, The Guardian also reported recently, so the major issue still is processed food, and added sugar is in most processed foods, but ultra-processed foods now constitutes half of the British diet, which even I was really quite shocked by. Half of the British diet is ultra-processed food. And actually, that's the most important issue. I know there are debates about saturated fat, which, looking at the evidence myself, is very clear is not linked to heart disease. But when we think about ultra-processed food, which is actually where a lot of the excess consumption of poor quality food and nutritionally poor food is coming from, what's really interesting is a separate study showed that ultra-processed food was linked to cancer. That was published in the BMJ. And I think this is an interesting slide because a lot of people talk about getting fat consumption down. Fat consumption has pretty much stayed the same. It's gone down slightly probably as a percentage, but it's stayed the same in terms of its amount. But actually, most of the processed food, if you look at this slide, is coming from starch and sugar. It's not coming from fat. Even processed meats is little on there, is a small chunk. So most of the processed food is coming from starch and sugar, and that's where people are really, this is what's driving the type 2 diabetes epidemic. Investment bank, Credit Suisse have even gone as far as to say the best way to tackle the type 2 diabetes epidemic is going to be from taxing sugary food and drinks. And even their analysis suggests that's going to be the best way forward. So what do we do? Where do we go from here? In 2015, I was a lead author on a paper that was signed off by some of the UK's most respected and authoritative doctors, part of the Academy of Medical Royal Colleges, and we've called for a campaign to really reduce the harms of too much medicine in conjunction with the British Medical Journal, because we know that there is a massive problem of overtreatment and too much medicines. And prescribed medications now are estimated by one respected scientist to be the third most common cause of death after heart disease and cancer. In the NHS, Sir Bruce Keir, the former medical director of the NHS, said about 1 in 7 operations and treatments are unnecessary and should never have been carried out in patients. So this campaign was launched and it got a lot of publicity. It was press released. The co-authors include Professor Dame Sue Bailey, who was the chair, now former chair, and even Professor Sir Terence Stevenson, who's chair of the General Medical Council. So we have realised that this is a big problem, and also that we have an ethical responsibility, because if there's a lot of waste going on in the system on treatments and medications that really are not benefiting patients at all and causing harm, then there's a maldistribution of resources, and that's an ethical consideration we have to look into. So we did give some next steps. I think the most important thing, I think for everybody to take away from this, if you are a patient going to see your doctor, I think the most important, we actually put a series of questions that you should put to your doctor. So the first thing is, do I really need this test or procedure? What are the risks? Are there simpler, safer options? And what happens if I do nothing? It's interesting that only 2 days ago in The Guardian, they reported on a study suggesting that we've got a big problem with over-medication affecting the environment now as well, that it's harming the ecosystem. It's even causing sex changes in fish and amphibians because of the amount of drugs from various antibiotics, anti-inflammatories, getting into the water supply, which is really quite disturbing. And the researchers here have said actually we need to reduce the amount of medications that people are taking. I actually think now we need a global campaign. Actually, we need a global campaign to reduce the amount of medications people are taking. In the UK, more than half of patients over the age of 70 now, of the members of the public, are taking at least 3 medications. I was speaking to Richard on the train on the way here, and I just think that's really extraordinary. It's really extraordinary that so many people are taking so many medications. So a little bit about Pioppi diet. It's a book I wrote, published last year, and this is based upon a southern Italian village which is considered one of the healthiest villages in the world. It's interestingly the home of Ansel Keys, the scientist that told us saturated fat was the cause of heart disease. And he spent a lot of time in this village, and it's an amazing place. If you ever get a chance to go there, you must visit it. It's not very affluent. And we went there to try and find what their secrets were, just observing the people that live in this community, which hasn't changed much over the years. And their average life expectancy is close to 90. Many people live over the age of 100, but they age well, and they're certainly not taking lots of pills, I can tell you that. We ate at the local restaurant. The man who was running the local restaurant was 85 years old. The next day, we saw him fixing his own roof. You know, these people age well. So what we did is we wrote a book, myself and my co-author Donal O'Neill, we wrote a book called The Pioppi Diet based upon marrying the secrets of this village and actually the best available evidence and research that we have on what constitutes a healthy lifestyle and how impactful that is for your health. And there are a number of myths that we bust in there. One of them includes the fact if you're over 60, high LDL cholesterol, the so-called bad cholesterol, is not associated with heart disease and may protect you from an early death. But I think most importantly, the message is this, and this is what I've learned in my career, is lifestyle changes are more powerful than any drug at both preventing and treating heart disease, and they come without side effects. So really, this is what should be at the forefront of medical care now to deal with the increasing burden of chronic disease. And an editorial I wrote with 2 very eminent cardiologists, don't just take my word for it. Professor Rita Redberg is editor of JAMA Internal Medicine, practicing cardiologist as well, like myself, and Pascal Meyer, also a practicing cardiologist, editor of Open Heart. We wrote an editorial in the British Journal of Sports Medicine, which became the most read, pleasantly surprised by this, of all BMJ journal articles last year. And it was basically saying saturated fat does not clog the arteries, and coronary artery disease is a chronic inflammatory condition, the risk of which can be rapidly reduced by lifestyle changes, simple lifestyle changes. And that involves what we call a high-fat Mediterranean diet, but basically a diet that is based on lots of vegetables, non-starchy vegetables ideally, olive oil, oily fish, nuts, and is low in refined carbohydrates and sugar. And if you do that, and you walk every day for at least 30 minutes, and you think about stress and getting a better sleep, actually this can overcome a lot of the burden of chronic disease. And interestingly, at the heart of this, as I said before, is insulin resistance. Insulin resistance is a precursor to type 2 diabetes. It's a number one risk factor for heart attacks. And about 50% of patients who have high blood pressure is rooted in insulin resistance. Now, how effective is this? What evidence do we have that this actually works? So this is a little anecdote of on Facebook. I've never met this person. I have lots of emails from people, and people send me stuff every day of their stories, which I just think is amazing. And this gentleman, with his permission, I told him I was going to name him and put his picture up today here. In Malaysia, there's a chap with type 2 diabetes who had it for several years. And essentially, from ignoring, he said here that he decided he didn't want to take a statin and metformin, probably because of side effects, I don't know. He ignored his doctor's advice and decided to follow the advice of things he'd read by people like myself and other people, as Jason Fung in America. And it's really extraordinary. He has essentially reversed his type 2 diabetes, or certainly come off medications. He's reduced his blood pressure. I've seen patients who've come to see me, one in particular I remember, who had been on 4 blood pressure pills, and within months of changing his diet, that's all he did. He's come off 3 of his blood pressure pills that he was taking. And he's come off his diabetes medications. So this stuff works. Now, some people would argue, hold on, this is anecdote. It's working for these people, but is there any other evidence for this? Well, there's some great work going on by diabetes.co.uk, an independent organisation in the UK. And they have done a lot of work where they've got a program which essentially is very similar to what we say in the Pioppi diet, is low refined carbs in the diet, no counting calories. And they have managed to show in a significant proportion of patients who've managed to come off their medications, certainly reduce their medications, most of them, many patients putting their type 2 diabetes into remission, which is really quite extraordinary. I mean, it's amazing data. And this is on thousands and thousands of people. In the United States, a very similar program being adopted by Verta Health. And in their program, in a year, 60% of their patients reverse their diabetes, and glycemic control improves, and they reduce the need for medications. Again, ignoring the government guidelines that say put starchy carbohydrates at the base of the diet and fear fat. This advice says don't fear fat and don't put starchy carbohydrates at the base of your diet. So we're getting towards the end now. I know other people need to speak and we're getting on, but I'm just a little quiz for you here. So as a cardiologist, I care more about heart disease than anything else. It's still one of the biggest killers and causes of premature death around the world. So a little bit of a quiz for you. NNTs, nothing easy to treat for heart disease, for death, okay? So if you take aspirin every day for 5 years and you've had a heart attack, so these people have had a heart attack, there's a 1 in 100 chance that taking a statin will save your life. Statins, if we trust the data implicitly, okay, you have to take it with a pinch of salt, industry-sponsored data, there's a 1 in 83 chance if you take a statin every day for 5 years and you've had a heart attack, it will save your life. Aspirin and statins at low risk if you haven't had a heart disease or have a heart attack. You don't suffer from heart disease. Infinity, you're not going to live 1 day longer from taking a statin. If you have stents during a heart attack, okay, so I said they're a life-saving procedure, with everything else we do, the stent itself, having a heart attack, an acute heart attack, there's about a 1 in 40 chance the stent procedure itself will save your life. Stents at any other time, well, you already know the answer. They will not prolong your life, they do not even prevent heart attacks. So what's the most effective coronary intervention tool we have, based upon published data that we have that's available? Any guesses for people with heart disease? What's the most powerful thing we can do? Mediterranean diet. Now, this is one study, and I admit there are limitations, but still that's very powerful information. That dietary changes, people with heart disease, had such a big impact on mortality, reducing heart disease. But we've sequestered that information, we've held it back. That information is out there, it's very powerful. And in this crisis that we have in healthcare, you know, when everybody in the room knows that a heart stent is not going to prevent a heart attack, but following the Mediterranean diet is the most effective tool we have, then that's when you have real transparency. That's when you have accountability. That's when you have real quality in healthcare. That's when you're practicing evidence-based medicine to help patients. And that's what we need more than anything else. And I would actually argue that holding back this information it's not just the fact that we are using biased information to make clinical decisions that least support patient outcomes and is unethical. I would argue this is an attack on democracy. This is an attack on the principles of democracy. People making everyday decisions on misinformation, on half-truths, that they would change their decision-making process if they were given the full information. And at the end, last year I wrote a piece in The Guardian, and I basically said it was covered in the Eye today as well. I said that essentially I think the situation is so dire with the fact we're not tackling research misconduct, the fact that there is too much commercial influence on medical guideline bodies, the fact that patients are not being given information in a transparent way, that it really needs a deepening. I think it's so deep-rooted, it's a system failure. It's not about pointing fingers at individuals. It's a system failure. It needs an inquiry on the scale of what we had with Chilcot into the Iraq War in the UK. And this is a quote from the second President of the United States, which I love, which is, "The preservation of the means of knowledge is amongst the lowest ranks, is of more importance to the public than all the property of all the rich men in the country." And my final slide, perhaps regretfully, the pioneering heart transplant surgeon Christian Barnard said towards the end of his life, "I've saved the lives of 150 people with heart transplantations. If I'd focused on preventive medicine earlier, I would have saved 150 million. It turns out lifestyle is that medicine." Thank you.